Yeah, so I was talking about the picture here. On the left, you can see the image of the cityscape within the Aboriginal flag, with the Aboriginal flag symbolizing the presence and resilience of Aboriginal culture within urban Australia. It serves as a reminder of the enduring connection that Aboriginal and Torres Strait Islander people have with this land, despite many changes that it has undergone. To the right is the beautiful artwork, Girama's Wattle Seed, created by Nathan Peckham, a direct descendant of the Tubaga clan of the Wiradjuri Nation. His intricate design reflects the deep cultural knowledge and storytelling of Aboriginal art, illustrating both connection to nature and the strength of cultural heritage. As we gather here virtually, I extend this respect to the traditional custodians of the lands on which each of you are joining from today. May we hold this acknowledgement in our minds and hearts as we move through today's discussions. Very, very warm greetings from sunny Sydney. I know we are probably the envy of our colleagues joining us from up above in the Northern Hemisphere. After all, there's a reason we are called Down Under, though I assure you the sunshine here is really quite real. As we come together from all the different corners of the globe, it is wonderful to connect across different seasons and time zones, some of you afternoon, mid-noon, and we are here early morning on a Saturday for today's important discussions. Thank you all for joining us wherever you are. It is giving me great pleasure to welcome you all to the first regional symposium of the Global Practice Initiative for the Americas and Western Europe. Today, we gather to explore case studies from across this region that underscore the impact of nurse-led initiatives on the upstream social determinants of health. These case studies not only highlight the potential for nursing to drive health equity, but also it illustrates the essential attributes that nurses need to lead effectively at this level, attributes like resilience, advocacy, strategic leadership. Our goal is to use insights from these case studies to inform best practice guidelines that will empower nurses worldwide in addressing the root causes of health disparities. Thank you for joining us, and a special thanks to our speakers and the Global Initiative team. I look forward to an inspiring day of learning and collaboration. Now, I would like to introduce the Global Practice Initiative led by Dr. Natalie Cutler, who spearheads this project as the lead researcher, with Dr. Albie Sharp as the co-lead. Dr. Cutler is a senior lecturer at the University of Technology, Sydney, and a prominent advocate in the international health initiatives. With extensive experience in mental health nursing and global health, she has led international study tours for nursing and public health students through the New Colombo Plan. She focuses her work on enhancing mental health and nursing globally, especially in the realm of social determinants of health. Dr. Albie Sharp, co-lead of this project and senior lecturer at UTS, specializes in public health and the social determinants of health, with his focus on non-communicable diseases and global health security. Distinguished Professor Tracy Levitt-Jones is a world-renowned researcher in planetary health, empathy, and patient safety, and has authored numerous influential works in nursing. Associate Professor Deborah De Bono is our Deputy Head of School Teaching and Learning in the School of Public Health at UTS. Dr. Deborah uses health systems expertise coupled with implementation science approaches to co-design evidence-based strategies to improve the implementation and evaluation of quality and safety initiatives in the delivery of health and social care. Dr. Mohammad Shutiami, lecturer at UTS, is an expert in epidemiology, community health, infectious diseases, contributing extensively to international health research. As for myself, Dr. Priya Sarvanakumar, I'm a gerontology researcher and a senior lecturer at UTS. My research focus is on older adult well-being, particularly in culturally and linguistically diverse populations. Hence, my immense interest in the topic that we are discussing today. Let's take a look at the agenda for today's symposium. We'll begin with our 3 case study presentations from our speakers, Grace Kistner, Dr. Ariana Chao, and Dr. Krista Schroeder. After the case studies, we will have an overview of the real-time Delphi process. Dr. Natalie Cutler will be giving the overview. This will guide us in gathering collective insights. Then we'll open the floor for an interactive discussion and Q&A session using Slido. Dr. Chutiami is going to be moderating the session, allowing everyone to engage in an open floor discussion. Here is a link to join through the Slido. And I have a few, just a couple of requests, just so that we have a very smooth experience throughout the symposium. Would I please ask everyone to mute their microphones during presentations to avoid any background noise? And feel free to keep your cameras on if you're comfortable, but if your connection slows down, turning off might help. And if you do have any technical issues, please let us know through the chat. And we'll try and reach you through the chat function. Yeah. And so for questions during the presenters sessions, as well as during the open floor discussion, we're going to be using the Slido. And please put in your questions for the presenters or panelists. Simply head to Slido using the QR code provided here. You can also upvote your questions from others, and we will be aiming or endeavoring to answer the most popular ones during the Q&A sessions. And I would like to remind or gently remind everyone the link that exists for the case study submission, and also to register for the next upcoming regional symposia. Now I would like to welcome Grace Kistner, a distinguished healthcare professional and board-certified clinician with extensive experience in global health advocacy and frontline leadership. Grace will be presenting the first case study of our symposium, drawing from her impactful work across clinical policy and international development settings. Over to you, Grace.
Thank you so much. Please confirm that you can see my screen.
Yes,
we can see it, Grace. Looks good.
So thank you for the introduction. I appreciate and respect the time and space offered by UTS, Upstream, Social Determinants in Nursing Practice, and everyone at the Global Practice Initiative team. I'm here today as a representative and co-facilitator of the Nurse Policy Entrepreneur Cafe. I am currently in the United States, and the other facilitators from its initiation come from Central America and Africa. This case study describes our nurse-led initiative for group mentorship, in which the cafe helps our professional identity to evolve for a health and all policy approach to reform. So thank you for your acknowledgement. And before I begin, I would like to take a moment to set an intention of presence and read another mindful acknowledgement, which has been adopted in part from the Peace and Justice Center that I believe aligns with the compassionate art of nursing and caring science. In the interest of time, I will let you read this all yourselves, and I will read the last point. So our work together is about disrupting and dismantling the oppressive systems deeply interconnected with historical and current violent structures. We acknowledge these systems of oppression impact our lives by creating a hierarchy around the voice, experience, and perspective of who is centered and uplifted. We believe it is essential in all of the work that we do to recognize whose shoulders we are standing on and whose legacy we are fulfilling, to work together to dismantle hierarchy and uplift the voices of those who these systems are made to oppress. So keeping that in mind and considering the reason that we are all here today, we recognize that nurses are first witnesses to the social determinants of health for our patients every day as we provide direct care. Our pedagogy is a holistic approach to care focused on upstream concepts of health promotion and disease prevention. Yet in our traditional practice roles, we meet patients who are already having sick diagnoses and need treatment and plan of care management. The polycrises of the world, inequalities, and broken systems have downstream effects that exacerbate these conditions, as well as our ability in our strained workforce to provide this sick care instead of health care. Politics with a big P and policy with a little p both influence the social conditions that generate health outcomes. This is the premise of Daniel Dawes' book entitled The Political Determinants of Health. Nurses keenly understand that health system strengthening expands beyond traditional direct care roles into cross-sector advocacy and networking within public and private partnerships. Nurses work in multiple spheres of influence to shape health and social policy that addresses problems in healthcare, including the workplace, in government, associations, and interest groups. We know well the determining factors contributing to these compounding issues, but sometimes we lack the knowledge, abilities, and confidence to identify and translate our skills away from the bedside to be able to address them upstream for health in all policy. Nurses have maintained our status as the largest and most trusted profession for decades, yet we're rarely engaged in the process of healthcare policymaking and reform. This gap not only is from a lack of invitation, but also nurses struggle to identify as thought leaders in this arena. The concept of a nurse policy entrepreneur, while practiced for some time, is often overlooked despite the nurse workforce's trustworthiness and size. Becoming engaged as a thought leader and policy influencer is an element of the nurse's professional identity, along with the beauty, the diversity in our individual perspectives, personalities, and leadership styles. If we leave it to other disciplines alone to determine the healthcare policy, reform will be marginalized. We must use our qualities and insights to become known as more than just the most trusted profession, but to be also one of the most influential when it comes to policy. But how do we address these issues? The Nurse Policy Entrepreneur Cafe is a nurse-led initiative which was built upon Parsi's human becoming theory and is facilitated using the World Cafe method. Establishing our mission, vision, purpose, and core values in 2022, our primary objective was to offer a psychologically safe space for structured group mentorship that fosters dialoguing, listening, contemplating, and constructing cycles for meaningful evolution of this identity. Rooted in inclusivity, it is open to all nurses and students at all levels from all settings. We meet in a virtual platform once monthly and exchange innovative ideas to achieve the primary outcome of developing necessary skill sets that are not learned in pre-licensure or entry to practice education. We learn the process of how to effectively approach the issues, not debate our stances on them, and serve as a compendium of resources. As a result, we are better poised to take on roles as full partners in healthcare reform and be articulate, trusted messengers who influence change upstream through policy and practice. Our participants serve as our proof of concept for how this environment supports increased knowledge, skills, abilities, and competence. We invite all participants to share their experiences through presentations and blog posts in a know one, see one, do one modeling that inspires others to shift from discourse to action. We are unaffiliated and unfunded, and we host a website that serves as a compendium for open access resources to get started. It continues as a living project for all to democratically contribute, and nurses can then apply what they learn in their practice setting, specialty, or passion topic. We also disseminate these concepts and resources via journal articles, conference presentations, professional organization forums, social media, YouTube, and a newsletter. Approximately 1 year after initiating the monthly Zoom cafes, our regular participants collaboratively contributed to an abstract for a national nursing conference presentation, which was hosted in the United States that focused on nurses' engagement with policy advocacy. This was the first in-person recognition of interest, and it set off a cascade. When we established a website where we then shared groups of different skill sets to focus on. Identifying nurses who have experience in each of those skill sets led to our monthly cafes evolving into a series of themed blog posts and speaker presentations followed by group discussion. Now we are writing retrospective summaries and an annual report of our most recent evolution. The nursing process is being used, and we seek to survey participants and subscribers to assess what they think will be most beneficial to focus on moving forward and what the best format is for dissemination. This is me presenting at that conference, which set off that cascade. And these are some of the examples of how I have shared my journey in blog posts, as many others have as well. But this is the broader example of an impact that even just one person can have. These are just a few instances from the past year of how I alone have been engaging increasingly in broader areas of policy change as a nurse. And I know that my experiences with the Nurse Policy Entrepreneur Cafe have been integral in facilitating my knowledge, skills, abilities, and confidence to do so, as well as help me grow my identity and network with other nurses. You'll notice the colorful wheel of the United Nations Sustainable Development Goals, which I believe can also serve as a proxy of sorts for the social determinants of health. This living project has organically grown, but there have been minor challenges and lessons learned along the way. Although we had nurses voluntarily join for up to 2 hours on a Saturday, we mostly remained a small group of regular participants early on. There was interest, but limited group contribution to getting started and compiling resources. At first, we used an affinity diagram via a virtual Miro board, but suspected technological barriers to engagement with this. After we began actively recruiting volunteers to share their experiences and disseminating, we saw more interest in participants and added this information to the new website. Because of this, we weren't sure if or how much this was garnering interest or helping nurses. Once we attached analytics to our online presence, we uncovered the interest and global reach. It showed thousands of engagements across all 6 continents. While there have been international participants, there will never be a single time or day where everyone can attend live. So this is why we have posted recordings online and tried to ensure open access and relevancy of all resources shared through various multimedia platforms. We have been approached now by some of these international participants, including other healthcare disciplines, social impact groups, and government workers. And we're now exploring the idea of facilitating others to host global cafes by continuing with our know one, see one, do one modeling approach as we strategically plan for the coming year. So that is my short and sweet presentation of this case study. Thank you so much for your time and interest. I'm honored to have this opportunity to share the cafe with all of you across the regional scope of this symposium, and I hope it offers insights and inspiration. I warmly welcome you to visit our website. I will put the link in the chat, and I welcome you also to make any suggestions or contributions that you would like to it. At the website, you can find the blogs, shared presentation recordings, sign up for a monthly newsletter, and the Zoom link to attend. We meet every second Saturday of the month at 12 noon Eastern Time. Our next one will be next weekend. Feel free to get in touch with us at the email on the screen or me personally via LinkedIn, which I will also share in the chat. And I'm happy to take questions at the end of our session today. Thank you so much.
Thank you very much, Grace. It's amazing and such an awesome work that you have been doing and very inspiring too. I'm sure the audience will have several questions to be shared during the common flow.
Thank you.
I'm going to share my screen again now. Next, we have Dr. Ariana M. Chao, Associate Professor at Johns Hopkins University and Director of Research at the Healthful Eating, Activity and Weight Program. Dr. Chao, an experienced family nurse practitioner, will present our second case study, focusing on innovative interventions for obesity and related eating behaviors to enhance physical and mental health. With over 100 publications and funding from the NIH, her research is shaping impactful health solutions. Dr. Chao, over to you.
Excellent. Well, thank you so much for that introduction and for the first presentation. I really enjoyed it and learned a lot. So I'm going to go ahead and share my slides. All righty, excellent. So as mentioned, I'm an associate professor and also work as a nurse practitioner in the Healthful Eating, Activity and Weight Program, which is the obesity treatment program at Johns Hopkins. And this is my funding and disclosure slide. I also have a branch of my research that is working on anti-obesity medications. So you can see that I've consulted for some pharmaceutical companies, highlighted here, Eli Lilly and Company, Epidemy Medical, Novo Nordisk, and have also worked with Weight Watchers. And today I'll be talking about some of my research that has been funded by the Edna Kynette Memorial Foundation, as well as NINR, National Institute of Research, particularly an R56 study. So my role is focused on obesity treatment. And as a reminder to all of you, obesity treatment is typically thought of as a pyramid where lifestyle modification really forms the foundation of all of treatment. This includes things like improving diet, increasing physical activity, as well as behavior modification strategies. And I did not plan this as Grace, but Grace had this in her slides as well. But I wanted to highlight here that social determinants of health really plays a key role in terms of all of these facets of obesity treatment, ranging from whether people even have access to their treatment. You know, insurance coverage has been a struggle for a lot of individuals seeking anti-obesity medications. But social determinants of health also has a really big role in terms of thinking about treatment for lifestyle modification. And this is really important too, because as we think about social determinants of health, studies have demonstrated that individuals who experience more adverse social determinants of health have a higher risk of developing obesity. So again, a really big patient population need. So in terms of taking action as a clinician, one of the things that has been really highlighted by a lot of different guidelines has been screening for social determinants of health. And this has been also included in different mandates from places like the Center for Medicare and Medicaid from CMS. In order to assess for individual social risk factors in healthcare settings, there are a number of different initiatives that have been taken place, including things like health-related social needs screening tools and embedding these into EMR and getting providers to screen for these different risk factors. And this is, again, an example of one. And another example, too, is using Z codes. So Z codes are social determinants of health related codes that can document different things like housing needs, food insecurity, as well as transportation. Again, highlighting and recognizing the importance of these factors in terms of patient treatment, as well as risk factors. So one area that I am particularly interested in, especially in regards to obesity treatment, is food insecurity, which is defined as limited or uncertain availability of nutritionally adequate and safe foods, or limited or uncertain ability to acquire acceptable foods in socially acceptable ways. For the screening, it can be done by 2 short questions. Within the past 12 months, you worried that your food would run out before you got money to buy more, or within the past 12 months, the food you bought just didn't last and you didn't have enough money to get more. So again, these screening measures are pretty short to be able to implement in practice. And again, highlighting this relationship in terms of the context of obesity, we know that about 42% of individuals with food insecurity have obesity. And it can create a cyclical cycle where individuals with food insecurity might have difficulty accessing food. They might be more likely to have things like depression or mood disorders, live in maybe physical activity deserts where they don't have access to green spaces or sidewalks to walk around. They might be relying on fast food more. They might have less healthcare utilization. This can also contribute to things like using food to maybe cope with different emotions, less bandwidth to focus on physical activity, which can contribute to chronic diseases like type 2 diabetes, high cholesterol, which might increase healthcare expenditures, decrease employability, lead to less household income, and then spending trade-offs where individuals might be choosing between, say, picking out healthy groceries or being able to afford medications. And then again, it can continue with this cycle over time. We also know that food insecurity is associated with worse weight loss during weight loss programs. And this has been replicated in a few different studies. And part of the reason why this is that intensive lifestyle intervention or lifestyle modification, which again forms the foundation of that pyramid, focuses on different things like dietary changes and caloric restriction, which is induced and maintained through increases in low energy density foods, things like fruits, vegetables, lean proteins, and then decreases in foods with high energy density or high calories. We also emphasize things like physical activity as well as different behavioral modification strategies, as you can see. However, it does little to really address different social determinants of health, which is a huge gap in terms of really being able to help patients in need. We know that food insecurity and food affordability are tightly influencing factors related to people being able to adhere to different treatment strategies that we might be advising them in clinic. So less energy dense foods like fruits and vegetables are more costly. And the monetary amounts provided by different nutrition assistance programs are oftentimes insufficient to be able to cover the cost of adhering to things like federal guidelines for healthy diets. In addition, about a third of people who experience food insecurity don't qualify for federal food assistance. So again, a lot of patients in need who might not be able to access resources. We also know that oftentimes foods that are less energy dense, fruit and vegetables, are harder to access, especially in different areas where there might not be grocery stores or where there might be a high number of individuals who don't have access to vehicles or cars to be able to get to grocery stores. So we know that living in a food desert and or a food swamp limits access to nutritious foods. And food swamps are places where there might be a lot of places like corner stores or convenience stores or fast food restaurants. And these really are overcrowding access to healthier foods. So if you think of yourself as a clinician screening for food insecurity, and you have someone who answers that they might be experiencing food insecurity, and they're also interested in losing weight to improve maybe different health outcomes like type 2 diabetes risk or blood pressure or improving obstructive sleep apnea, what do we do for these patients? And this has been a struggle, I think, and why the adoption of some of the things like Z codes has been suboptimal in some settings. It's because if you screen it and don't have a lot of tools to be able to address it, then it can be really frustrating for providers. So these are some different options that people might think through. So can we tailor care? So this might include things like focusing more on low budget fruits and vegetables, using frozen produce, making sure people are really being able to stretch their dollars in terms of their nutrition. Referrals and connections. So these could be sort of passive referrals where individuals might have, say, a list of resources in the EMR that are sent to the patient or printed off at the end of the visit, or active referrals, which tend to result in better resource linkages, where there might be an individual who actually is able to help someone to be able to navigate and really connect with the different resources like a food pantry, or help them register for something like SNAP or WIC. And then a big gap in terms of obesity treatment is the provision of resources. And this brings me to a review that I did looking at food insecurity and behavioral obesity treatment to kind of look at what is the evidence behind different practices that are being done to address food insecurity within obesity treatment. And for this, we only found 5 studies, so there wasn't a lot of evidence. And much more is needed. So there were 2 main types of interventions that were being done. One was obesity treatment counseling with and without tailoring for food insecurity. And then the other was different subsidies to increase food access. So 2 of the 3 studies included counseling alone, and these were essentially to see if individuals lost less weight during behavioral weight loss, one of the studies I showed before. And then 3 of the 5 studies included interventions to increase food access. So this included things like subsidized membership to a community agricultural group, grocery store gift cards, or using meal replacements. But there was really a lack of studies that evaluated behavioral weight loss treatments or lifestyle modification programs, plus food as medicine approaches. So food as medicine approaches can take a variety of different forms. And these are interventions that are really focused on recognizing that food is an essential part of health. And that oftentimes clinicians might be counseling patients to have healthier diets, but patients might not have the resources to be able to do this. So what can we do clinically? At the population level, there's different healthy food policies and programs. There's government nutrition security programs, produce prescription programs, medically tailored food package, and medically tailored meal programs. So there's pros and cons in terms of thinking about challenges like scalability as well as sustainability, kind of thinking about the efficacy for each intervention and condition. Here we're talking about obesity treatment, so it'd be looking at weight loss as well as other chronic conditions related to weight. Things like cost of the program. Obviously, the medically tailored meal programs tend to be fairly expensive, oftentimes because these might be frozen foods that might be delivered to individuals. So cost is a big factor. Again, how scalable it is, how willing are people able to adhere to different types of programs, as well as things like sustainability. So again, highlighting some of my research, I'm just going to go very briefly over some of the studies that I have done. One is looking at different produce prescription programs, and this was funded by the Edna Kynat Foundation. We call this the Produce RX pilot study, which was to examine the feasibility and preliminary effects of a program that combined these food bucks that we got from the Food Trust in Philadelphia, combined with a behavioral weight loss program compared to waitlist alone. It included weekly 30-minute individual in-person lifestyle counseling sessions with content tailored for individuals with food insecurity. And then individuals were provided with $20 at each session. This is highlighting the adherence. So we had fairly good adherence for people coming to their sessions. So the mean was 10.5 out of 12 sessions attended, and individuals used 67.5% of their food bucks, which were redeemable at select farmers markets as well as grocery stores. These, I'm not going to show a ton of data, but just wanted to highlight that the total score for their actual dietary quality, which was measured using 24-hour dietary recalls, numerically increased in the Produce RX 3.9 points compared to the wait list, but it wasn't statistically significant. And then you can see here that both groups had declines in calories. We did see differences in terms of weight. So for the Produce RX group, they had a weight loss of 2.4% compared to the waitlist group who had a gain of weight. And then there was greater improvements in weight control self-efficacy in the Produce RX group, as well as greater improvements in physical health-related quality of life. So what this showed is that the program demonstrated preliminary feasibility and efficacy compared to the waitlist group. The Produce RX group produced an improvement in dietary quality, but was not statistically significant. And we did find improvements in weight control, self-efficacy, as well as health-related quality of life. This next study, I'm just going to show you a little bit of the design. It's a preview. We're currently analyzing the data, but this was funded by the National Institute of Nursing Research. And this was called the Food RX Pilot Study. And this particular study was geared towards the fact that oftentimes, as I showed before, we have this food as medicine pyramid, but we don't know which food as medicine approach might be better for certain outcomes. And again, this has really big implications for thinking about sort of scalability as well as long-term feasibility and sustainability. So this is looking at whether food supplementation interventions improved weight loss, health-related quality of life, and dietary quality in individuals with obesity and food insecurity. And again, looking at what type of food supplementation intervention is most effective. And for this, we have a group that's randomized to behavioral weight loss alone, again, geared towards increasing knowledge, skills of how to change diet, which hopefully is going to increase behavior change and dietary quality and improve weight loss.
Dr. Chao, there's 3 more minutes. Sorry to interrupt, but 3 more minutes.
No, thank you for the time reminder. And then there's a behavioral weight loss and voucher group, which again has increased knowledge. And then the voucher hopefully will increase the salience of importance of eating nutritious foods, because individuals are given a gift card to a grocery store, and they're able to go through with their counselor different fruits and vegetables that they might be able to purchase with the gift card, but they have more flexibility in terms of what they're actually spending it on. And again, it helps to remove the cost barrier to nutritious food. And our last group is focused on a behavioral weight loss intervention plus home delivered groceries. So this can not only address these other barriers that I introduced before, but also increase the convenience of nutritious foods, which might be important, especially for individuals who might be living in food deserts or food swamps. So this is the study schema. So we'll be looking at changes from baseline to 24 weeks. And again, the results are coming soon, so hope to be able to share those with you soon. But in conclusion, for food as medicine, in terms of thinking about obesity treatment, there's a clear in terms of evidence-based gap that's needed to be addressed. And in order to do this effectively, we really need studies that are larger samples, looking at longer treatment, looking at things like sustainability, both at a patient level, how long do we need to provide the food supplementation for? And then if food supplementation stops, are patients able to sustain different behavior changes long term? Also looking at things like site level factors and the availability to implement these different programs inside of clinical settings. And lastly, I think Grace really cued this in, but the importance of thinking about different pathways to policy, really thinking about nurses who are able to advocate for these sort of initiatives to be implemented in healthcare settings as well as federal programs. So with that, I'd like to thank you all so much for your attention. I'm looking forward to the discussion.
Thank you very much for that wonderful presentation, Dr. Chao. I bet there'll be many questions on the innovative ways or the different ways that nurses can contribute in this space. Yeah, thank you very much. Can everybody see my screen?
We can.
Yes, thank you.
Yeah, thank you. Great. I would like to, I'm delighted to welcome our third presenter, Dr. Krista Schroeder, an associate professor at Temple University College of Public Health. She's a nurse scientist, clinician, and a clinician whose research addresses the impact of social determinants of health on chronic disease, particularly in trauma-affected populations. Dr. Schroeder integrates GIS, quantitative methods, and trauma-informed approaches in her work, all while actively practicing as a critical care and emergency nurse and serving as a sexual assault nurse examiner. Over to you, Dr. Schroeder.
Great, thank you so much for the introduction. I'm going to pull up my slides here. Okay, you should see my PowerPoint, correct?
It's,
Excellent.
that's right. Yeah.
Perfect. Thank you so much again for the introduction, for the opportunity to be here with you today and contribute to what has already been a very engaging session of presentations. I look forward to sharing with you some of my early work around the role of school nurses in addressing social determinants of health related to childhood obesity. So as far as a brief outline of what I'll be covering, I do want to provide a brief introduction specifically to the positionality and lens in which I approach the work that I do. And I appreciate the introduction previously given, which will help frame that. And then I'm going to dig more deeply into a case study of one specific nurse-led childhood obesity intervention, including how the intervention was implemented and its effectiveness, and how we can understand that implementation and effectiveness and really thinking about the context of the social determinants of health. And then ending by sharing some of my thoughts around what's next and looking forward to hearing some of your thoughts and the other presenters' discussions on what could be next in this space and related spaces. So here I've included my positionality statement. I typically tend to be averse to very text-heavy slides, but because I think this is important, I've included it word for word here, but I'll briefly summarize it narratively for you. I believe as a scholar that one's identity certainly influences the work they do and the way they approach it. So I want to share a bit about my own background, identify as a woman and as white. I'm a faculty member at a large public research university in Philadelphia in the United States of America, which is a community that, while it has many strengths, has also experienced a lot of barriers related to social, economic, and racially driven marginalization. Most of my research, as was mentioned, focused on social determinants of health, particularly in populations affected by trauma. But an important part of that research for me is directly engaging with patients to inform how I understand my work, ask questions, and interpret my work. So I do maintain an active clinical practice in the community in which much of my research is based. So with that, I would also like to amplify the fact that I don't do this to speak for the populations I study, but to leverage some of the privilege that I hold to help amplify their voices and the importance of the issues I study. So with that, let's shift gears to speaking about school nurses and obesity. So I have here two screenshots from the first pages of articles, one published several years ago and one published more recently, in which I was involved that examined the evidence and found that school nurses or nurses based in school settings can be really important stakeholders in helping to reduce childhood obesity. And that's what the literature as a whole tells us. But let's think together more deeply about one particular intervention that I was involved in helping to evaluate. And that's the Healthy Options and Physical Activity Program, or HOP. HOP was a school nurse-led intervention for kindergarten through 5th grade children with class 2 to 3, what we historically called severe levels of obesity. It was implemented here in the United States by the New York City Department of Mental Health and Mental Hygiene and the New York City school system. The program itself entailed one-on-one counseling sessions with a child and a school nurse with an intensity that was dictated by the nurse, but meant to be at least once every 6 months, with time focused on health behavior education, goal setting, and BMI tracking, really focused on obesity-related health behaviors, sugary beverage intake, screen time, physical activity, etc. And the New York City school nurses were provided with training and resources, but there wasn't a particular structured curriculum. They were given a lot of autonomy to tailor the program as they saw fit for the children they were working with. So how were eligible children in New York City potentially enrolled in HOP? Well, in the New York City school system, the BMI percentile of all students is measured annually as part of their physical education. And for students who had a BMI greater or equal to the 99th percentile, which was New York City's metric for determining highest levels of obesity, a letter was sent to the parents explaining the HOP program, and opt-out was offered. And if the parent didn't opt out, the child was then eligible for enrollment by the school nurse. So essentially, if the parent didn't say, I don't want my child to participate, the nurse had the opportunity to enroll that child. And if a child was enrolled, their actual engagement with the school nurse focused first on just an assessment of comorbidities, assessing the child's BMI percentile, providing, of course, some health behavior education, setting goals, and providing some take-home materials for the child and family, with follow-up sessions then being focused on measuring the BMI percentile again, providing additional health education and revising goals as needed based on progress, and ensuring the child and their family were linked to school and community resources as needed. And all of these sessions occurred one-on-one between the child and the school nurse, as I mentioned previously, though parents and caregivers were invited to participate if able. So my role in this project was, after HOP had been in place in New York City for several years, I came in to do an evaluation study in collaboration with my Department of Health colleagues to evaluate how HOP was being implemented, if it was working to improve health behaviors related to obesity and decrease BMI percentile, and also to better understand school nurses' experiences implementing the HOP program. And those first two items related to implementation and effect on behavior and BMI percentile were assessed via a quantitative research study, though the third bullet was assessed via a qualitative research study or interviews with school nurses. Oops. And because the focus of our work today is in part how school nurses can play a role in addressing social determinants of health, I just wanted to provide a little bit more detail and examples of the types of interview questions we asked school nurses. These were developed using a framework called the RE-AIM framework, which is a theoretical framework that can be used to help evaluate an intervention's implementation and effectiveness. So it's just exemplars here. So when we began our evaluation, what did we find? Well, in New York City, almost 21,000 children were eligible for HOP, which is 5.7% of the student population. That's a very large number, but the New York City school system is a very large school system with over 1 million children. So even if only 5.7% are eligible, that's a lot of children. The demographics you can see in the table below, I won't read them to you, but you can see a larger percentage of the sample that were eligible were male, of Black race or Hispanic ethnicity, and were approximately 7.5 years old. That's about consistent with what we see when we look at the demographics of youth with this level of obesity in New York City. In particular to this presentation today, I did want to highlight that we looked at some of the contextual factors impacting these youth, that children eligible for HOP lived in high poverty environments or lived in neighborhoods where an average of 1 in 4 of the families that lived around them were living below the poverty level. When we looked at implementation itself, we determined that HOP implementation was actually quite rare. Less than 1% of parents opted their child out, yet only 1,049, or 5.1% of the eligible children, were actually enrolled. And of those who were enrolled, they participated in an average of, or a median of, 1 session per school year, so quite low intensity. And parent presence was quite infrequent, with parents being present at only 3.2% of HOP sessions. And not surprisingly, given the context for that low intensity intervention, there was no effect on change in health behaviors or BMI percentile. And interestingly, given that low enrollment rate, we wanted to explore what factors were most associated with an eligible child receiving HOP, or a child who is eligible HOP actually being enrolled by the school nurse. And the strongest predictors were a child attending a school with a lower nurse workload or less school poverty. So essentially, if a child attended a school where the nurse was less overworked or there were more financial resources, the child was more likely to receive HOP if they were eligible. And the school nurse interviews we conducted were really important to giving context to some of the social and environmental factors that were influencing why we saw what we saw when we evaluated the implementation and effectiveness. So we spoke to 19 nurses from all different areas of New York City, different levels of experience. And one of the main findings from those interviews were that the social and environmental factors were really important to understanding HOP. So I'm going to provide some example quotes of how that came to light during those interviews. So first things first, this relates to the presentation we just heard, thinking of food insecurity, food environment. A lot of the nurses recognize the importance of the context of the nutrition environment around where children were living and attending school, with one nurse noting, "There are too many fast food chains in the neighborhood where my school is. So if parents can get fries and soda and chicken nuggets for $1.99, why would they cook?" Parent beliefs about obesity and the school nurse's role were notable as well. One nurse noting, "I can't even begin to tell you the phone calls that I received. It was basically, how dare I intrude?" Many parents felt that this was not the school nurse's role to intervene on obesity, especially for such a sensitive topic. School culture played a role as well. The culture of an institution or an organization is always important, and that was the case here. Some nurses noting that as a facilitator. So for example, the teachers at the school where I am are very receptive. That helps a lot. I don't have any of the students saying, oh, or the teachers saying, oh, you can't take the student out of class for HOP. Social discrimination was another substantial concern, particularly weight-related bias. One nurse being concerned saying, yeah, it's bad enough being a heavyweight child, let alone being embarrassed in front of the class. Oh my God, she has to go and get a lesson from the nurse because she's fat. To that point, nurses made some creative efforts to minimize stigma. For example, thinking of creative ways to invite children down to their office to be educated without tying it specifically to the HOP program. This nurse provides an example of, I had a little girl who came to my office as a helper in decorating. I said, I need to coloring these pictures of fruits and veggies, so could you help me do this? While she was coloring the
Dr.
pictures.
Schroeder, 3 minutes more, 3 minutes more.
Thank you. Working conditions played a role as well. Nurses noted, have you ever walked into a medical room in a public school? It's very busy. Nurses can do a lot, but they cannot educate 1,000 children about nutrition, and that's a fact. One nurse saying, I'm so busy, I feel guilty. I want to spend more time with these kids, but I just can't. I just don't have the time. Family socioeconomics also played a big role, perhaps not surprisingly. Some nurses making an effort to let families know that there were area farmers markets available that took public assistance programs to be allowed to play for fruits and veggies. But considered collectively, looking at the quantitative and qualitative results, we noticed that HOP had low enrollment and intensity, rare parent involvement, and variation in implementation with no effects on outcomes. And nurses faced a fair amount of barriers related to the social determinants of health. They did use some creative methods to overcome those barriers in implementing HOP. And to this end, my colleagues and I took some of the lessons from this and wrote a call to action about the need for school nurses to address social determinants of health and being so well suited to do so. So I have a few thoughts, and I won't go into these too deeply because I want to touch on them in discussion, but when I think about the reasons in this project and elsewhere why nurses may not play the role in social determinants of health that they potentially could, I see a lot of exclusion from their decision and policy making. I feel nurses aren't always prepared for and confident in advocacy and policymaking skills. That's why it's so wonderful to hear about Grace's work. Nursing expertise isn't always valued by individuals in positions of power. I've noticed that not only as a clinician, but a fair amount of times as a scholar. And I think sometimes as a profession, we need to do a bit better job being more outward facing and how we advocate for our role here. However, we have to consider this is all occurring with competing priorities and resource-constrained environments. Nurses are very busy, and sometimes when thinking about how to best address the social determinants of health, whether it's related to this specific obesity intervention or more broadly, nurses feel helpless or powerless because they don't have the skill set or resources to make those type of upstream changes. Yet, I want to close on a note of hope and optimism by saying that I fully agree, as do I'm sure many of you, and that's why you're here, that nurses are arguably among the best suited to address social determinants of health in the healthcare profession. And I'm really very appreciative of the Global Practice Initiative team and the folks on this call doing this work for their work related to this important topic. So for next steps, I'm starting to do some more work. The project I presented earlier was my first work in this space, so I have evolved a lot since then, but I wanted to share that with you because it was very specific to your request for a nurse-led case study. But my more recent work is really thinking more about the intersection of trauma with some social determinants of health, thinking about innovative ways to measure school and neighborhood characteristics, and continuing to work with school nurses, as well as learning every day from my patients to inform the research that I do.
Dr. Schroeder, but that time is up. But thank you. That was a brilliant, I mean, you showcased the work that you have done that is so impactful, and you also highlighted the challenges, and you pretty much nailed on the purpose of why this initiative was formed as well, as to the importance of nurses' voice and the nurses' role, given that they're the largest workforce in the world, in the healthcare system in the world. Yeah, thank you very much.
Okay. Thank you very much. I appreciate that. And I'm going to stop sharing because we're on the last slide here, okay?
Thank you. Now, now we are moving into the next, a brief overview of the real-time Delphi process by Dr. Natalie Cutler. Over to you, Dr. Cutler. And shortly after Dr. Natalie Cutler provides the overview, gives overview, I would like all of us to please stay here with the cameras on, because we want to take a group picture as well before we proceed on to the open floor discussion. Thank you. Over to you, Dr. Natalie.
Thanks so much, Priya, and thank you very much to all the speakers. What a really uplifting set of presentations, and diversity of ideas and thinking. And I know there's lots of questions in the forum to come. Now, my internet is not particularly stable today, unfortunately, so I'm going to turn my video off just to save a little bit of bandwidth if it helps. So this is a very brief presentation to let you know about a little bit more about this project and an associated research study that we are doing that may be of interest. So this project, the Global Practice Initiative, is a piece of work being done under the auspices of the Worldwide Universities Network. We have a number of partners, some of whom are members of the World Universities Network and some who are not members of the World Universities Network, and they are listed here, and you can see more about them on our website. So we are a collaborative of universities that have an interest in developing the capacity of nurses and health workers to influence at the upstream social determinants of health. So our study, the study that's being undertaken under the auspices of this project, excuse me a second, my slide just won't transition. There we are. I'm just showing this slide as a lovely little colourful image that captures what we're talking about when we talk about the upstream factors and the things that we're talking about. And it includes the laws, the policies, and the regulations that affect the community, the conditions that people live in their communities. So that is absolutely what you've all been talking about in your presentation. So thank you. So the study that we're doing is entitled "The Critical Role of Nurses in Addressing the Upstream Social Determinants of Health and Advancing Equitable Healthcare Practices Globally." So that's the focus of our study. And our project team, or our study team rather, are these people listed here, most of whom are here today on the symposium. That's myself, Dr. Sharp, Dr. De Bono, Professor Tracy Levitt-Jones, who some of you may have heard about, is a world-renowned researcher in the area of empathy and clinical reasoning, and more currently planetary health and nurse leadership in that space. Dr. Saravana Kumar, who's our wonderful MC today, Dr. Shudayami, who you'll hear from shortly, and Professor Michelle Rumsey, who is the director of the World Health Organization Collaborating Centre for Nursing and Midwifery in the Western Pacific region. So the aim of our study is to bring together experts from nursing and related fields to reach consensus on what would constitute best practice guidelines to empower nurses' capacity to influence the upstream social determinants of health. So we're going to conduct a real-time Delphi study, and I won't read all of this out, but unlike a traditional Delphi approach, where there are discounts of inquiry, a real-time Delphi approach allows participants, it's fully online, allows participants to asynchronously review the questions, look at the responses others have given, and revise their opinions throughout a set time frame. It is a very dynamic and iterative process for expert consensus. And it also has a geographically dispersed panel of experts to contribute within a defined period of time. So it's an effective and a very inclusive way of gaining consensus on a particular topic. So the outcomes of our research, what we're evidence-based guidelines for best practice that can be used to inform nursing education, nursing registration, and also scope of practice for nurses globally. And we hope to bridge the gap between theoretical knowledge, our thinking processes, and what's really possible in the real world. And that's where the case studies that you've presented this morning, sorry, it's this morning here in Australia, but today, the case studies really are fantastic exemplars of real world nursing practice, of nursing leadership in influencing these upstream social determinants of health.
Dr. Cutler,
so for more
time
information.
Yeah, please go on.
It.
Yeah, that's what I was asking. Yeah, the time is up, but then, please go on, because they want to hear more, information as to how they could reach out.
Yeah. So, well, that's my last study there. So for more information, jump on our website, or you're welcome to email me if you would like to participate in the study and be able to contribute as an expert panel member. Thanks, Priya.
Thank you. Thank you very much, Dr. Cutler. And thanks, everyone. Now is a group photo time. Could I please request everybody to have their cameras on? And I'm going to ask Dr. Chutiami to please help with taking the screenshots. Dr. Chutiami?
All right. So I think we're in. Yep. Are we in gallery view?
Sorry. Yeah.
Yeah. Let us know
Hello,
when it is
everybody.
done.
It's so
We're all trying to freeze our smiles, I guess.
Okay. 3,
Just
2, 1. Yeah, I've taken one. If somebody can take another one.
All
Lovely.
right. If there's just a couple of cameras off, if it's possible at all for Ariana maybe, and anyone else that would like to turn the camera on, but I can take another screenshot. So maybe one, if we could just wave now. Hello. All right. And hang on, I'll just ask one more. 1, 2, 3. Thank you, everybody.
Oh, the benefits of online.
That's fine. Thanks.
Get-togethers, isn't it? Yeah. We wouldn't be able to do this in person, but this is great. Yeah. Thank you very much, everyone. Now we will move on to the next. Now we'll move on to the next session. The next part of the symposium. This session will be moderated by Dr. Mohammad Chutiami. Sorry, Dr. Mohammad Chutiami, my apologies. So this, we call it an open flow discussion, purely because we want everybody in the room to engage. And unlike traditional panel discussion, this is going to be, equal engagement. That's what we're aiming for from everyone present in this symposium, so that we can learn and share from the insights that's gained from everybody's experience. And this session will be moderated by Dr. Chutiami. The facilitators will include everyone who has, every member of the Global Practice Initiative, as well as the case study presenters. And I believe one of our colleagues is already collating the questions through the Slido, and the questions will be, again, I will leave it to the efficient hands of Dr. Chutiami. Thank you.
Thank you so much, Priya, and thank you, Grace, Associate Professor Ariana, and Associate Professor Krista. That were great presentations touching different aspects of social determinants of health. So just before we go into the general discussion, I will point 1 or 2 questions that are very specific to your presentations, and then we take the general discussion questions. Starting with Grace, one of the questions was that apart from the activities that you do as part of your initiative, are there specific activities that members of your cafe undertake in their own communities? Meaning to say they get influence as a result of what you do to implement something similar in their own communities?
Yes, absolutely. So you can find on our website the blog posts as well as the recordings of the speakers who have shared what they've done in their own communities. There's a wide variety of what they've done. We had a speaker who was the president of the Colorado American Nurses Association, and she actually implemented the very first acute care nurse practitioner program at University of Colorado Anschutz. So that was a mix of state policy. She advocated at the state government level, but also implemented the program academically. We've had someone who is the executive director for the Commission of Nurse Reimbursement write a blog for us. That group is advocating for federal policy change for reimbursement for nursing services. We've had the executive director for the Nurse on Boards Coalition. So that's someone who's actively advocating to get nurses on boards in various arenas to influence different policies within organizations. We've had active political campaigners, lobbyists, and people who run for office themselves. We've also had hospital policy level change for an emergency room nurse in Oregon who implemented a new policy for what happens as a response after staff are assaulted in the emergency room. And we've had some nurse practitioners who advocated for local health policy for full practice authority. Just as some examples.
Lovely, lovely. These were great examples, and we can see so many things already taking place. And thank you so much. Just a quick question. Has your work so far influenced nursing curriculum in any way you are aware of?
So I personally am not in academia as faculty, but I have influenced personally some nursing education that is academic adjacent, if you will. I've advocated and lobbied for removing DEHP, which is a phthalate and plasticizer out of IV medical tubing and bags. And I am now part of a working group that's creating nursing education campaign as to what that is and why it's important. And to get the information out outside of California, where I currently am. There's also global consortiums of nursing education, notably for planetary health. There is a global nursing school community practice that I joined there every other month webinars or Zoom sessions to collaborate with them, even though I am from the practice arena, not academic arena. There are professional organizations that provide entire mini academies for this type of training as well.
Lovely. Thank you so much. I think I will leave it due to time factor and get to Ariana. I know your work is still ongoing in many ways, but see if you have anything to add to this, to respond to this question. After adjusting for salary or financial status, did the researchers still find significant association between obesity and food insecurity, which I know your work is ongoing, but I thought to put it across. And then we have got another question still for Ariana that says, have you been able to include the people, for example, with obesity as co-designers in some of the activities that you do?
Yes, I will start with the second question, which is yes, we do engage both individuals with obesity as well as a community advisory board on our studies to get feedback. And I think pilot work is oftentimes really important just in general in research to get a lot of great feedback from the participants themselves, not only about the research process, but also about what we're providing with them. So we've been able to get a lot of qualitative feedback about the different programs and what they liked and didn't like about them, and then are able to use that for other studies as well as improving the program as well. To the first question, I believe they're asking about observational studies, and the adjustments, I would say, for socioeconomic, it's a little bit hard to do with food insecurity because they are correlated and related. I'm not positive if they typically have adjusted for those that I have seen, though Krista might also have thoughts about that too. I have mainly been in the clinical trial arena in terms of thinking about sort of intervention development and less on the observational side. But because they're so related, I think they are really intertwined, and it would be hard to, in a way, dismantle them. So I think there is a relationship, but food insecurity is tied with economic status as well as education.
Lovely, lovely. Thank you so much, Ariana. And I will quickly jump to Krista. Just one question before we get into general discussion. Is there any advice you can give to help prepare nursing students in the work that you do?
Yeah, thanks for that question. And it's something I spend a lot of time thinking about. I think perhaps one of the most important ways to do so, and we've actually published a paper on this, is purely just having students deeply engaged in community-based work as part of their nursing training. So much of our nursing training in the States is focused on clinical experiences and hospitals. Obviously, that's very important. That's where many new nurses begin their career. But having deep engagement in the community as part of their clinical, particularly repeated engagement with the same community setting over the period of a semester or semesters has been helpful in both some of our quantitative evaluation of student progress as well as just anecdotally from students and preparing them to do work focused on the social determinants, with the caveat that students need to be prepared for that work going in. So not something you necessarily want to try with maybe first-year students, but once they're a little bit further along in the program and have a framework for understanding equity and social determinants, and then providing them with the opportunity to spend some time doing deep community engagement as part of their program. I think that can be one of the most promising ways.
Absolutely. Thank you so much. And now open to everyone. Of course, we have had 3 amazing case studies ranging from the mentorship program to food insecurity and school-based program for children obesity. So the most important thing I think we should start is, what are the unique skills or training that nurses require to undertake activities like the one we have had in the presentations today? So if you want to put your hand up, and then I will call a name, or you can, just speak up. Anyone? Yeah, okay, thank you so much, Grace. I can see you. Grace, go ahead.
Considering that the cafe helps nurses find a space to build these skills. I would encourage everyone on the call to look up Simon Sinek, who's a thought leader in inspirational leadership. He has a very poignant YouTube video from a TED Talk from 2009, which is relevant today. And it's about how great leaders inspire action. And it starts with everything you do. The core of what you do is starting with your why. So find your passion, find what you're really, really passionate about, and find the intersection of where you can do good in the world for social impact and also what's needed. And whatever's in the center of that is where you're going to find a lot of success. But beyond that, you must find good mentorship. And we say that we started the cafe to provide a psychologically safe space, but I like to call it now a brave space, because it encourages nurses to think differently about their skills. For example, the nursing process here in the United States, we teach ADPI, right? That is project management. but nurses don't think of themselves as project managers, but that's what we do every day. So think about what skills you already have in a different arena, in a different light, and challenge yourself to use them differently. Think and read and write a lot, and the more you practice, the more you'll be really well suited to be an articulate messenger.
Lovely, lovely. Thank you so much, Grace. These were great advice on the skills and training required. Anyone else, particularly from our audience? Anyone want to speak up? Can I see hands?
Yes,
Yes, please.
okay.
Go ahead. Yeah, go
Hands
ahead.
I absolutely agree with what Grace just said there, that definitely, you know, having a clear sense of your motivator and your intrinsic motivators and your, you know, extrinsic kind of drives is really important. Having mentors and people that you can see doing work that impacts is so important. And we hope too that forums like this become those opportunities for models of practice at this level to be visible and showcased. And I'm also interested in how the presenters, but everybody, you know, thinks that we can build in the capacity for what I believe is needed, which is a certain amount of courage and bravery, because to challenge the you know, to influence the upstream social determinants of health does require sometimes challenging, quite entrenched policy settings. And so the courage, how do we prepare nurses to have that courage? I guess would be the simplest way to ask that.
Lovely, lovely. Thank you for adding those, Natalie. And I've got Krista. Want to add anything? You are muted, Krista.
Oh, goodness. Zoom 101, unmute before you speak. Okay, now I'm ready. I appreciate both those prior comments. And the one piece I'll add, which is an aspect I think a lot about, is how those of us, given our expertise or our positions of power, depending on where we are in our careers, can help change systems to make it easier for nurses who feel confident, who feel prepared once we have them prepared, to make those kind of changes. Because I know, both when I think of my role as a clinician, but also primarily as a researcher working with nurses in this capacity, a lot of the barriers they face, even when they're acting brave, courageous, strong, they're coming up against so many system level barriers, time, money, lack of leadership buy-in, that it at times leads to them experiencing burnout, frustration, feelings of helplessness, and trying to make those changes. So I don't have the answer, but I like to think about how we can work on both ends. We have those wonderfully prepared, motivated nurses who are so passionate, but we're also helping them to work in systems that aren't presenting so many of the barriers that they are in the way our current healthcare system, at least in the USA, is structured.
Lovely. Thank you so much, Krista. Any last thought before I get to the next key question? Yeah, thank you, Ariana.
I'll just add something really brief, which I think is encouraging people who might not be invited to some of these conversations to at times invite themselves, really to, you know, make sure that people are, you know, recognizing that you might not be invited to the table, but you have to sometimes, you know, build your own chair and bring it with you, or make your own table and invite people to the conversation to recognize that nurses are leading in this space and have really great innovations and also implementation strategies to be able to really make a difference in this area.
Lovely, lovely. Thank you so much. Great responses. Just to add a similar question to this, I know you have mentioned some of this as part of your discussion, but I want to hear the audience opinion. We do a lot of work as nurses that influence social determinants of health, clinical, community, schools, and everything. But I think the most important thing is how can our work influence policy that impact the public, can be a hospital, can be an entire country or a state. So I wonder what our thoughts are with respect to how can this work influence policy for the greater good. Anyone who wants to start the ball rolling? Policy, yeah. Thank you, Ariana.
I can start a little bit. And I sometimes think about policy broadly, both from the governmental perspective, but also for things like health insurers. And I think having conversations with them to be able to understand, okay, what is it that you value and what are you looking for in some of these interventions? That way we can add things like different, measurements for things. Sometimes it's about scalability and then being like, this intervention would not really be able to be implemented on a widespread scale. We're going to have problems with coverage of it. And really having those conversations early on in terms of sort of, okay, what metrics would you be looking for can just be really helpful in order, because sometimes they speak also like a completely different language, like there's terms like return on investment and just things that, economists are involved in, all different sort of individuals where I might not be thinking about that as a clinician. So, making sure that we're kind of having a really holistic view in terms of what their priorities might be, but then also making sure that I'm sharing what my priorities would be as a clinician in terms of seeing health benefits and really helping people improve their health.
Absolutely. That makes a lot of sense. And actually, we have got a comment also in the chat that says the idea of encouraging more nurses to be on board and to lead the conversation is great, which I believe so. Yeah, Priya.
Yes, I just would like to add my thoughts on this, which, as I believe all of us are, thinking about this. And I believe all of us have been thinking about it during the time we have been nurses, which is, several years, decades in some cases. Yeah, so the one thing is, I believe it is important to, especially looking at the novice nurses or emerging nurses, nursing students, it's really important to give them a bit of strategic thinking, because I think that is important in today's world to find a place, to know our place. I think it's really important to know the key people, for example, within Australia, knowing who are the nurse leaders, who are the policymakers who have a say, and knowing them on a, who is who on a name by name basis, I think is important as well. And having the thinking as, kind of like a leader, how can I get this across? Because the passion, we do see that we are often, as an educator, I get inspired every day when I interacting with my students, because I see a lot of passion there. But sometimes as experienced nurses and academics and influencers, I believe we have a responsibility in helping them guide, showing the channels. And in today's world, with the modern technology, with AI and everything, I believe this is much more easier than a few years ago. And I believe that's in one way, it is advantageous. We are living in a better situation, but on the other hand, we are also living in a very volatile environment as well, with climate change, political insecurities, war going on. And so it's a very complex world that we are living in. And I believe it is important that we encourage our nurses to step up. And I think it should start from the individual level as well. Thank you.
Lovely. Thank you so much, Priya. And we have got some important links shared by Albi on TED speech, and then another link shared by Ariana. So if you want to have a look, just click on the link. And yeah, let's get one more. Grace?
Yes, but just to quickly add on to the last point made, to emphasize that we need to encourage and teach students how they can be active in this, and get them to think critically about their position when they enter practice, but that they don't have to wait until they're in practice to take action. There are definitely, student nursing associations is the very first and easiest way to get involved, but the youth is really, they're our future, but we don't have to wait until the future for them to act. They can act now.
Lovely. That absolutely makes sense. With our number and everything, I think we can start to make a difference even as students. And lovely. Thank you so much, Grace. Anyone else from the audience thinking about policy? Otherwise, I'll just throw in a very quick last question. I know we're heading to our time limit. I know during the presentation, Oh yeah, don't need to wait for till the future to act. We can do it now. Lovely. That's a good point. I know during the presentation, a lot of you have mentioned some of the difficulties, and I believe if anyone wants to initiate any intervention or initiative, challenges are things that we can help it. So I wonder if we can point out some key challenges that you probably had gone through, some of you that have implemented your initiatives, or something just to take in mind going forward if a nurse is to implement an initiative similar to what you have done. Just quick response, 30 seconds possibly.
I can start. I think
Yes,
for me,
Ariana.
finding funding is always challenging, as many of the researchers know. Being able to provide something for someone. Sometimes I've heard of folks getting sort of like donations of things, but again, finding funding and the resources I think can be really challenging. And then thinking about what that means actually in terms of sustainability for any of these interventions and how it will be funded long term.
Lovely, funding, big issue. Thank you so much, Ariana. Anyone else? Key challenge you can think of?
Yes. I'm sorry. Yeah. Let's.
Krista,
This will
just
be.
one more.
Yeah. This will be a final
30
comment,
seconds.
and then we can move on. Yeah.
No problem. I'll be quick. This aligns with some of what we've heard before, but having pride and confidence in your role as a nurse and knowing how to advocate for the value you bring, because sometimes others won't recognize that, but learning how to make the case for why a nursing perspective is important in spaces in which they're typically excluded.
Absolutely, absolutely. And thank you so much, everyone. I'm sorry even for the questions. There is no much time, but thank you. That was a great discussion. Over to you, Priya.
Thank you. Thank you very much to everyone for all the contributions. Very thought-provoking, very inspiring. And I would like all of us to continue the conversation even beyond this symposium. And yes, thank you very much. I'm just going to quickly share my screen again. Yeah, so this is just a reminder, for people who are interested and who have those case studies, which highlights the nurse initiatives or the interventions taken forward by nurses to, submit the case study. And using this link, the next regional symposium registration. So the next upcoming regional symposium is going to be focusing on Africa and Eastern Europe. And the date is towards the end of November, the 22nd of November. And I would like to, encourage people to, the audience to please register yourself using the QR code that is over here. And as we conclude today's symposium, I really want to extend my heartfelt thanks and gratitude to our presenters for sharing their beautiful, invaluable insights, and to each of you for your active participation. Your engagement today underscores the importance of collective efforts in addressing upstream social determinants of health, and also highlights the pivotal role that nurses play in driving the systemic change. We hope you found today's discussions inspiring and are motivated to implement these insights in your own practice and networks. Please remember to visit our website for more information on upcoming sessions. Feel free to reach out to info@sdohpractice.org, which is available on the website as well with any questions. Thank you once again, and we look forward to continuing this important journey together. Please share what you've learned with your networks, and we hope to see you at our next regional symposium.